Okay, welcome back. Assalamu alaikum wa rahmatullah. This is Dr. Alsharif speaking. We are going to discuss about the management of patients in relapse setting by a few cases and different scenarios. The first case actually younger than 65 years old, fit, high-risk cytogenetics, treated with first line, then had first relapse within less than 1 year post-autologous stem cell transplantation during lenalidomide maintenance. Is there anybody can be volunteered to help us, and what can do with this patient? Anybody from the audience can tell us what should the treatment goal be for this patient? Go back to the scenario, please. Okay, this is the scenario. Any volunteer from the audience? Yeah, Sahar, try to unmute the audience so they can participate in this, because this is a matter of discussion, not a talk. I cannot hear anybody. Is there any volunteer? Are you hearing me?
Yes, doctor.
Are you hearing the audience? Are you hearing me?
Yes.
Okay. Who is hearing me?
Yeah, I am Dr. Hayat from Breast Hamad.
Ahlan, Dr. Hayat. How are you doing, Dr. Hayat?
Fine, Dr. Sharif, fine.
Okay.
Can we follow the regimen?
Okay. What's your opinion about this scenario?
Can we use carfilzomab including regimen as KD or KDD?
Carfilzomab, okay. Okay. Do you have any elaboration of the scenario itself?
As you said, this patient relapsed on lenalidomide maintenance.
Thank you. Yes, you're right. But here we have to think carefully about the case, even with the retrospective views, that this patient was 65 years, fit, and was diagnosed with high-risk cytogenetics. So the induction here really, and the line of the management should be in form of that patient will have the first transplantation with probably a different regimen induction, and then tandem transplantation, because this is a high-risk cytogenetic, you see? And if we shall think about that, this patient has high-risk cytogenetic, has to have actually tandem transplantation. Probably the best induction treatment should be given to him, then tandem transplantation, and then that will be followed not only by lenalidomide maintenance, because he's a high risk. So nowadays, actually preferable to combine IMiD in form of lenalidomide with proteasome inhibitor, which is Velcade, as a maintenance. And that might give the patient a better chance to have a better response as well as deep response. Having we mentioned that, so what can we do at this stage? Khalas, the patient already underwent one transplantation, started on one drug as maintenance. What can we do now? And he is really presenting with a relapse. So we have to be very careful. This is a young patient, fit, with high risk. So we have to choose whatever best combination for a relapse to give him. For example, as you mentioned, carfilzomib, but in combination with monoclonal antibodies and dexamethasone. For example, KDD, carfilzomib, daratumumab, and dexamethasone. Probably this is one of the best drug. Because according to Candor study, as we did see when I presented, actually, it showed really there was a very good response, but at the same time, fatality. And they mentioned that the fatality was in those elderly patient and the frail patient. So this is opposite to our patient. He is fit. He is younger than 65. That means he is young. So carfilzomib, daratumumab, dexamethasone, one of the best drug can be given to this patient. However, because he is young and fit, we have to avoid doublet treatment at all. He should be treated with the best triplet regimen. And I think carfilzomib, daratumumab, dexamethasone is the first one for it. Is there any objection or any elaboration on this answer? Dr. Hayat, what do you think?
Yes, I'm totally agree with you.
You agree with this. Thank you very much for agreeing with me. Thank you, Dr. Hayat. Any other body would like to give more elaboration on this case? So, Dr. Hayat, for example, this patient, you gave him carfilzomib, daratumumab, and dexamethasone combination treatment, and mashallah, tabarakallah, he is responding. What you will do after that?
I think I will continue till disease progression if the patient is responding.
You will continue the same regimen until disease progression. Do you like to take him for a transplantation, for example?
Of course, I will take consultation from transplant team about this case. Of course.
No, not the, you are the doctor. He is in your clinic now. Are you going to advise him for second transplantation?
No, I am not a transplanter team, but I will take consultation, definitely from consultation.
Yes, right. I will answer these questions. Really, this patient relapsed too early after the autologous stem cell transplantation within 1 year, i.e., second transplantation not going to work with him. You see the clue, where is it? Yeah. Once the patient is really relapsed early after the transplantation, if he is in lenalidomide and he relapsed less than 36 months, second transplantation is not going to benefit him. While if he is not on, if he did not receive lenalidomide maintenance, might be we can allow up to 18 months, and if he passed that 18 months and he relapsed, then second transplantation can be thought about. This is one. Second thing that really, as you mentioned, that we have to continue the same regimen with him until he will develop side effects or develop disease progression. Suppose if that you continued this medication beautifully, and fortunately he did not develop any side effects. He was tolerating the drug very well, and at one stage he relapsed. What will be the other option? You follow me? So here at this stage, really, the other options is somewhat difficult. Again, we can give him combination of treatment differ than what we gave him early. You see, other thing that this patient, he might go for CAR T-cell therapy, even though it is not yet approved. But such a patient really with high risk, he relapsed, and then he developed a second relapse after a good combination of treatment. That CAR T-cell might be a clue for him. Some people will think about, even though we are not encouraging allogeneic stem cell transplantation in these patients, but again, allogeneic stem cell transplantation, if the CAR T cell is not available, if the new medications, for example, the new medication like bispecific monoclonal antibodies, bispecific, not available, or there is no trial going on to include this patient, might allogeneic stem cell transplantation is an answer here, you see? But keep in mind, please, allogeneic stem cell transplantation, don't think about it except in rare occasions, okay? So the second scenario, please, case 2. So this is case 2, younger than 70 years old, unfit, you see, and no transplantation. He was treated with some combination without transplantation, and he did well for 20 months, but unfortunately, he then relapsed. And the treatment he was given, Velcade, melphalan, prednisone initially, because he was unfit, so they chose for him VMB. Anybody can elaborate on this scenario? Okay, yes? Okay, let us to take it one by one. He's younger than 70, so he's not that old really, but he's unfit. That might be, he has comorbidities with heart disease, with chest disease, or or chronic kidney disease. So he is unfit for some reason, or poor performance status. And he did very well for 20 months with VMB. So we can choose a different drug for him. For example, we have to avoid a proteasome inhibitor, even though the duration is not that long, is not that short, really. 20 months is good. But we have to switch to another class of treatment, especially it is available. For example, IMiDs like lenalidomide. When lenalidomide combined with dexamethasone can be given to those patients who are not fit, or frail patients actually. Or if you are interested in combination, you might add the oral proteasome inhibitor, ixazomib. You see, but I would prefer really to treat this patient with RD, Revlimid and dexamethasone, and to really to evaluate well his unfitness. If he can tolerate full dose of dexamethasone, that's fine. Otherwise, you can drop the dose of dexamethasone to 50%. Instead of giving him 40 weekly, give him 20 weekly. That will be enough for him because he's unfit, you see. So here you can just play with the dose as your patient going to tolerate, okay? So, so RD here probably going to be the good answer, even though you can give him different new regimens or new drugs, but you have to be careful. For example, yes, he is really not elderly, 70 years, is in for multiple myeloma, is an ordinary age, because the majority of the patients diagnosed with multiple myeloma, they are 70, 75, you see. But here, because he's unfit, so use monoclonal antibodies can be used in those patients who are unfit. But you have to be careful whether really unfitness is severe or moderate or tolerable. So monoclonal antibodies can be used either, it can be used as a monotherapy or in combination with dexamethasone, small dose. So these are the two options for this patient can be given. Any objection or any answer, any question from the audience about the case 2? Okay, thank you very much. And we can switch to the other group because the time is now Oh, there is a case 3. Are you interested in to see the case 3 here? So the case 3 here, more than 80 years old, frail, dependent upon family, no autologous stem cell transplantation, first relapse 12 months after the combination BMB or RD. So what can you give such patient actually? Here really to think about yani, minimal treatment because he is already more than 80 years. And you have to think about the side effects of your treatment for this elderly patient, because usually elderly patient, they are prone to develop side effects, complications from the medications, and so on. So you have to be very careful when you are going to treat them. So here might be monoclonal because you already used this drug here, VMP or RD. You see, so might be monoclonal antibody as a monotherapy will be fine for this patient. Okay, so we can switch to the second group. Thank you.